actually going to set up the live now. So we are streaming live on Facebook as we speak, and I'm still trying to get Harry in here. We're still getting our faculty together and our attendees are growing. Hello to everybody. I'm looking, Harry, are you still here with me on the phone? Okay, I see a phone number that might be yours. It's trying to log in. Are you calling from your computer or from your? Okay, so I'm going to disappear for a moment, ladies and gentlemen. Let me deal with this. We're almost there.
Malin, can you do his talk if he can't, or you don't even have access to it?
I don't have access to it. I mean, if he can email it to me, I can, but I mean, I have not seen it yet. I didn't think about that. But we can actually, yeah, we can, yeah.
Just a reminder that we're live streaming at the moment.
Mm-hmm. Well, I'm just trying to think through an alternative if we can't get Harry on the line shortly.
We'll get him on in just a second. He's right there. And if I don't get him on in a second, we're going to start do intros and go into Malin's or my talk first, actually. So then somebody else is going to have to help him while I'm doing my talk. Harry, we got to get you on. I don't know what the problem is here. We did it.
I see a lever.
I see a lever. Okay. So, ladies and gentlemen, welcome to the next stop in our Bighearted tour. I am here with some of the staff members of the HCMA and some of our panelists from the Cleveland Clinic who you're going to meet throughout the evening. I'm sorry we're getting a little bit late of a start. Just to remind everybody, we are streaming live on Facebook, and you guys got to all watch the pre-meeting. We're going to work on that for next time. And those of you who are participating through Zoom, you're in the room with us here. So if you're watching through Zoom, there's going to be a couple of housekeeping issues I want to take care of real quick before we start our formal introductions. The Zoom viewers will be able to ask Q&A during the talks. There's a Q&A option at the bottom, and that's going to help you ask questions, and I will be moderating those questions as we go. They should be general questions to topic. We'll try to leave a few minutes after each talk for that. If you are a Facebook viewer, we are not taking questions from Facebook tonight. We are only taking questions through the webinar. There is a link on Facebook so that you can join the webinar in progress during the entire evening. At the conclusion of the presentations and the Q&A to the public, members of the meeting will be invited to a meeting room. This is a webinar, that would be a meeting room where you will be able to ask more informal Q&A of our faculty members at the conclusion of the meeting. That is not available to Facebook. This event is being recorded and it is being live streamed. The private meeting room at the conclusion of the meeting will be a little bit more private, not completely private because other members of the meeting will be there, but you will be able to ask questions that will not be broadcast through the web system that we utilize in the world. So you can make your questions personal and a little bit more quiet on the side. So that being said, there's a couple of other quick housekeeping issues that I want to take care of before we begin, and that is a poll. I'm going to ask all of the participants, not the panelists, who are joining us to take this quick poll. And it's just going to give us an idea of who we're speaking to this evening or who's joined us at the beginning of the meeting. So tell us a little bit about where you're from, where you're currently getting your HCM care, and what your HCM journey has included. So I'm going to leave that poll up, and I'm hoping that you can all see that poll. Okay, here we go. There you go. You're finding the poll now. So when I get a few minutes under my belt on that poll, we will bring that back, and you will see it. I will leave that open for a little while here. So I am going to hand over for introduction purposes to Melinda Desai of the Cleveland Clinic, who's going to tell us a little bit about what they have in mind for us tonight, and then I will come back to you.
Thank you, Lisa. Good evening, everybody, or if you are in a different time zone, good afternoon, good morning, what have you. I'm Melinda Desai from the Cleveland Clinic. I am a cardiologist here. I am the director of the HCM Center. I've been here about 15 years now. It is truly an honor.
I don't know.
It is truly an honor to be hosting this event. I sincerely would like to thank everybody on the webinar as well as the Facebook Live page for joining. Hopefully, you will come out knowing more about the disease than you did, or if you already did, then it will be a validation of what you have learned. It is, I mean, we have our group of folks here. I mean, everybody knows Lisa. Everybody knows, hopefully would also know Amy and the folks at the HCMA, but it is my tremendous honor to introduce my colleagues who will be on the conversations tonight. Most, if not all of you know Dr. Lever, Harry Lever. My colleague in cardiac surgery, Dr. Nix Madeira. Betsy is our lead contact. Betsy Stowski is our lead contact person in our resource center. She's a nurse by training, and she makes the trains run on time. I am Melinda Desai, and what we are going to talk, what we have decided today is, so I will give you a picture of where we are, or what's some of the new stuff happening. A lot of new stuff is happening in HCM, not just new drugs. A lot of new stuff is happening. Where we are going. Harry is gonna give his world view. He's got probably more experience dealing with HCM patients than most, if not any other living human being that I know. And his passion speaks for itself, himself in terms of having taken care of these folks. So Harry will talk about, give us pearls about diagnosis and management of HCM patients. And Nick, Dr. Smadera, I've heard a lot of patients call him Saint Nick, and there's a reason for that. He has done a lot of good surgically for HCM patients in the way of myectomy, as well as innovative operations to help cure your symptoms. He probably has done more myectomies than most, if not any other cardiac surgeon. And Betsy is gonna tell us how to get to the Cleveland Clinic. It is a big place, but to me, Cleveland Clinic is a big place, but a small village, okay? And it is one of the main things I hear from patients is how daunting it looked when they were coming in to begin with, but at the end of their visit, how impressed they were at the nimbleness of the organization and how smoothly their visit went. So she will give us some pearls of how to navigate their visit to the Cleveland Clinic. So and Lisa, of course, is going to talk about HCMA and what she brings to the table. So without further ado, I would like to introduce Lisa to give her presentation. And thank you all for joining.
You're on mute, Lisa.
I was going to remind everybody to keep themselves on mute when they're not talking so background noise doesn't interfere. And I think the new line in the world is you're on mute and everybody is listening to. So before we begin in earnest, I'm going to end the poll and I'm going to share the results with you just so you get an idea of who's here tonight, where they're from. So we're from all over the United States. We've pretty much got every quadrant covered, as well as we've got Canada, Europe, and someplace else. We'll find that out later. I'm going to guess Australia. We got a lot of Australians out there. So where are you guys getting your care right now? Just my local cardiologist is about 18% of you. An HCMA recognized center of excellence is 33%. Both a center of excellence and a community cardiologist is 21%. And 28% are past Cleveland patients. What have you experienced? You've had medication. Some of you have had septal reduction, either myectomy or alcohol septal ablation. We've got ICDs. We've got 2 transplant people here. They happen to be on faculty for the HCMA, but we're represented. AFib and ablation. So we've got a nice group of various experiences with HCM. So I am going to make myself share my screen. And we're going to go to this screen, I think. Share. There you go. Now you've got your welcome screen. So, oops, I forgot to fix the top of this screen with the right name. So we're just going to go to the next slide where we have the Cleveland Clinic information for tonight. Sorry about that. Last minuting doesn't always do me so well. So tonight in the Bighearted tour, you got a rundown from Dr. Desai of what you're going to hear. You're going to hear from the surgeon that my daddy trusted with his heart, and I did as well. So that kind of says something there. And I'm not sure if my father still holds the record for the largest left and right atriums, but he did for a while. Yeah, it was pretty big. He didn't have a myectomy though. That's a whole other story for another day. And then we're going to get into the Q&A as I discussed before. I'll take this opportunity again to tell those who are viewing on Facebook that we are not taking Q&A on Facebook. We're just streaming through Facebook. If you want to participate in the live Q&A, please use the link on Facebook and come join us here in the webinar. So there's a meme going around Facebook, and I thought we were going to start this meeting on the right foot today because the world is really crazy and COVID has got us all nuts. So when I saw these memes, this is a kitty cat going for an ultrasound because they think the kitty cat might be pregnant. But those of us who've had echocardiograms when we don't know quite what's going on can kind of relate to how this cat is laying on the table. Like, whoa, where are you putting that probe? And looking a little confused. And we've all been enamored by looking at our own echocardiography right over our shoulder and watching our heartbeat. And then when they tell us we have HCM, I think our reaction is very similar to this cat when it finds out that it's pregnant. What? So I think this summarizes what somebody newly diagnosed with HCM feels on a regular basis. And I hope you enjoy my humor. But if you don't, we'll get together on something else. But I love the cat. So why is HCM so complicated, and why is the HCMA necessary? Well, many of you have been told over the years that you have a lot of different things, diagnoses, that account for your symptoms that in fact are related to your hypertrophic cardiomyopathy diagnosis. Asthma, athletically induced asthma, panic attacks, anxiety attacks, depression, mitral valve prolapse, and innocent murmur. When you look at all of these factors and you put them through an electronic medical record system and you add in things like family history of heart disease, family history of stroke, family history of heart failure, transplant, etc., surprisingly, you come out with HCM being the common thread for all of these different factors. So we're trying to help raise awareness and understanding through multiple platforms on what HCM is and how patients with HCM can get to proper care. So why is it more important than some people might realize at this point? There's old data that was echo-based data that told us what the prevalence of HCM was, and we ran with that for many, many years. We thought it was 1 in 500 because that's how many echoes we would see. You'd go look at thousands of echoes from the community and you'd find left ventricular hypertrophy that meets the diagnostic criteria of HCM in 1 in 500. But then MRI came out and we realized we weren't seeing everything with echo. And then genetics and family members, we began to understand this better. So now what we're dealing with is the realization that it may be as frequent as 1 in 200. Now, not everybody's symptomatic, and they may take a while to come to detection, but it's really probably as common as about 1 in 200. So basically what we're talking about is somewhere between 750,000 and 1 million Americans have diagnosable hypertrophic cardiomyopathy. To those of you watching from out of the United States, I'm not disparaging you. Your prevalence is just as common. I just don't, the international numbers work into the tens of millions. So just US, we're talking about 750,000 to 1 million. And only right now, about 140,000, 120,000, depending upon which database you look at, only about 120 to 40,000 of us have gotten to care and been diagnosed with HCM. So there's this huge chasm where we're undiagnosed, and we need to work through the processes that exist in this country with the medical system that we have and the legal system that we have to try to help these people get to diagnosis. And we have some programs that we're going to be launching that are going to help us do that. So first off, I want to make sure for the purposes of this meeting and everybody's understanding who's watching, that we're all talking about the same thing. So hypertrophic cardiomyopathy, we know is related to sarcomeric mutations in about 50% of those who we know have HCM. We do genetic testing, we find a sarcomeric mutation, which is the contractile protein inside the heart muscle, and that's abnormal in most people with HCM. At 50% of them, we can identify the genetic mutation that causes the disorder. Then there's a group of people that we know have classic HCM presentation, but we can't find a gene. Doesn't mean they don't have HCM, it just means we haven't gotten there yet. We don't know enough about genetics. We don't know all the places to look. Are they going to be sarcomeric mutations? Are they going to be in some other protein within the DNA? We don't know yet, but we know that this group makes up those who act most like somebody with hypertrophic cardiomyopathy and would use the services of an HCM program. But HCM is a spectrum of disorders. And in the pediatric population, they define HCM a little bit differently than they do in the adults. And there's some inconsistencies in how we define it. In pediatrics, any LVH, they'll call it HCM and they'll attach it to another syndrome, when in fact it's actually part of maybe a non-sarcomeric mutation for something like Danon's disease or a metabolic or a storage disorder, AMP kinase, Fabry's disease. why is it important to know the difference? Because they have different treatments than the sarcomeric or unknown mutations have. So we want to make sure people are getting in the right pathway. And at the end of my presentation, I'm going to give you a link so that you can all get free genetic testing, and we can link you to services that can help confirm whether your HCM is known genetic mutation, unknown genetic mutation, or something in the spectrum of disorders that looks like HCM. So we know that there are different pathways that patients with HCM travel in their experience. So you're either asymptomatic, and we hope that you stay that way for a really long time, or not forever, and you're viewed to be at low risk of sudden cardiac arrest. So remember, asymptomatic and risk of sudden cardiac arrest, they get confusing sometimes. You don't have to have symptoms to be at high risk. So that's part of why a center of excellence really matters, to help figure that out. But if you're viewed at low risk, gene positive, or low risk, asymptomatic, then there's a follow-up schedule we put you on. And we keep an eye on things so that things don't get out of control. And if your gradient starts going up, or your heart starts to become less compliant, more diastolic dysfunction, they can get in and intervene earlier to hopefully keep you from being symptomatic by intervening. Then there's the other pathways, the sudden cardiac arrest risk, which are treated with ICDs and drug therapy, progressive heart failure, which can lead to the need for myectomy in those with obstruction. And then there's advanced heart failure with non-obstruction, and that's my pathway. And that's drugs, devices, and transplant. And then there's the rhythm management issues for atrial fibrillation, for stroke management. So there's these different pathways. And when somebody says, hey, I've just been diagnosed with HCM, what cardiologist do I need? Wrong question. What team do you need? Because all of these are subspecialists within cardiology. And why does it matter to go to a high volume center? So I've recently put together a presentation for the American College of Cardiology, which will air later this month. And we were taking a look at the question, why high volume care? So I looked at the data that the ACC has in their registry, and this is the average number of patients a cardiologist in America sees per year. And that's 2,000 patients in their practice. So if you have 2,000 patients in your practice, and 1 in 500 to 1 in 200 people have HCM, you got about 10 people with HCM in your practice. And the chances that they're all the exact same presentation of obstructed or high risk of sudden death or non-obstructed or AFib, not going to happen. So they're going to have onesie, twosie in each of those barrels. And that's not going to give you, the patient, a high level expertise and knowledge about how to best treat your presentation of HCM. And I can guarantee you, both Nick and Harry and Melinda will tell you, they've never seen two that are exactly alike. They're always a little bit different. So why does it matter to have somebody who has high volume experience on your team? 20% of us are going to be at risk for sudden cardiac arrest. 70% of us are going to have obstruction and disease progression. Some of it's going to be slow, some of it will be fast. 20% of us are going to be in that burnt out, non-obstructed phase, and hopefully you stay static there for a long time. If not, you got to go to transplant. And then that AFib group is about 20% again. So you want high volume experience in this particular area. The low risk asymptomatic, maybe you don't need a center of excellence all the time, but we certainly recommend you check in periodically to make sure you're getting the latest and greatest in our current discoveries. So what is an HCMA recognized center of excellence? Well, there's the cool logo, but it is a network of programs that we have spent 24 plus years, almost 25 years, building up so that patients with HCM can get to high volume care. Now, they're not all created equal. And I'll tell you, 24 years ago, when I was starting the work of the HCMA, one of the very, very, very first people I spoke to about HCM care was Dr. Harry Lever. And I said, hey, I think I want to start this group. I got this idea. And he's like, we need to help these patients. And I went, I think I found somebody here who's kind of special. And over the next 24 plus years, amazing things happened in this one center. But I knew that as much as I loved Harry Lever and as much as I loved Barry Marin, they are in fact mortal. So we needed to make sure that there was an infrastructure around to make sure that patients were protected. So we started to build centers of excellence. And as of today, we have 41 centers of excellence in the United States, and we have 8 sitting in the office waiting for review. So that is just a phenomenal growth. But all centers are not created equal. What does a center consist of? So again, HCM is serious stuff, so we need stick figures to make us laugh a little bit. So first you need a HCMologist. And I must tell you, the person who coined the phrase HCMologist is none other than Harry Lever. So we like the name, we're sticking with it. You can treat non-obstructive patients and still be a HCMologist. That's my official take on that. So the HCMologist is kind of the center pivot point of the program. He's the director. He's the one that's going to see the majority of the patients. Now, most of the time, it's a non-invasive cardiologist who has special training in cardiac imaging that leads the program. Sometimes they come from heart failure, occasionally from interventional cardiology, and very, very rarely electrophysiology. So we want to make sure that it's a team, it's cohesive. The imaging, the EP needs, the heart failure needs, the genetics, the mental health needs of these patients are being handled in a very systematic way to make sure nothing gets missed and nothing sneaks through a crack. So as the HCMologist evaluates the patient through imaging, through electrophysiology, deciding where people need to go, they all go out to their own little baskets. And then they come back. And I'm going to explain part of why it's important for them to come back. Early on in our experience, when a patient developed atrial fibrillation, they were sent off to electrophysiology. And sometimes they kind of stayed there. And they didn't come back to the HCM program until their ventricles were pretty much destroyed by the AFib. And the imaging people are like, well, why didn't you send them back earlier? And the EP is thinking, well, I was really worried about controlling their AFib, and I didn't think they needed you. It's a team. HCM does not affect only one part of the heart. It affects the whole heart, the whole body, the whole family, the soul, you name it. It affects us. So we want to make sure that there's some continuity in that care model and that there's a touch point, and that HCM Center of Excellence coordinator, director is the go-to person. So we want to make sure that all of our programs have this structure. Now, some of them don't have surgery. They refer to places like the Cleveland Clinic. And some places have smaller surgery programs that can handle a basic myectomy. But if you have some tricky anatomy, you want to go to somebody who's seen a couple hundred of these a year. So even some of our other centers of excellence actually refer to the Cleveland Clinic for complex surgeries to this day. And I suspect it'll stay that way for a long time to come because of the expertise level of this program, as well as Mayo and Tufts. So that's what we are talking about in terms of high volume. Now, there's going to be a document coming out very, very soon. It's the new updated guidelines on the treatment and management of HCM. And they've kind of taken up the HCMA Center of Excellence philosophy, although I don't think we were named in it, but whatever. And in that, they talk about 3 levels of care for those with HCM. Comprehensive HCM Center of Excellence, a primary HCM center, and your primary cardiologist. Now, they rate who should be getting what done by which specialist with some stars. Yeah, I put my own stars together, and the HCMA has its own viewpoint on what's high volume and when you should be at high volume, when a smaller center is appropriate, and when your primary is appropriate. The critical thing to mention is everybody should have a community cardiologist. Somebody at your local hospital should know you in case there's an emergency and you show up someday having a problem. You don't want to get to know the local cardiologist in the ER. Bad idea. So you need that anchoring point at home, and then you need your relationship with your center of excellence and have a regular check-in. Sometimes it's annually, sometimes you can go 2 years between a visit, but I wouldn't recommend going much more than 2 years between that visit because so much can change. So when the ACC, AHA guidelines come out, we'll be doing a special talk on that, but this is generally the concept of center of excellence care that the guidelines are going to talk about. So what do patients get? What is their perspective on a center of excellence care model? Well, they think that their care is better. Their physical condition is better. Emotionally, they are better. They feel more in charge and more aware of what's going on. We know that the outcomes from invasive procedures like myectomy, alcohol ablation, even AFib management are better at high volume centers than lower volume programs. And being involved in a bigger program gives you an ability to participate in clinical trials and enhanced research, and you can, have your voice heard in a different way in the clinical trial experience. And there's a lot of that going on right now in HCM, and it's really important that we all have an opportunity to participate. You can't do that at your local doctor for HCM. You can't do it in many of the smaller programs. You've got to go to a larger program typically to be involved in clinical trials. So we know that surgical mortality is way lower at a high volume center. We know that the likelihood of a patient being treated with the appropriate level of care is much more likely to happen in a center of excellence than community-based physicians. To this day, I still see things like dobutamine stress test being used to figure out if somebody's obstructed, or vasodilators given for chest pain and obstructive HCM out of a community hospital. So these are things that you won't have happen in a large volume center. So I'm going to pivot to talk about some HCMA programming. Those of you who are watching on Facebook now obviously know how to find us there, but for those who are watching in the webinar or might find this on YouTube later, these are our official communities on Facebook. We have a page. We have 2 groups right now, and we'll be building out those groups to different international affiliates that will be part of our HCMA program coming up in the next couple of months to year. So we're going to have satellite programs, in a sense, developing in different nations. And North America will stay together. US and Canada will kind of stay together in this page. But for those who speak other languages, for those who are on the other side of the world, may speak English, but are in way different time zones, we're going to set up private groups and private group chats for your community, and they'll all be listed on the HCMA website, and will be the anchor for HCM around the world. So that's kind of cool. We're going to be working on our online support group system. We've trained, as of this week, 24 online support group leaders who will have a variety of different types of support group rooms available. Some of them will be based kind of regionally. Some of them will be kind of driven by the personality of the leader, because they have some really interesting ways of coping and communicating. And some of them will be, focused on particular topics. We'll have a monthly pre-myectomy. I'm planning on my myectomy meeting. We'll have regular ICD groups. So if you want to know about getting those procedures done, you want to understand it from a really intimate point of view from people who've already been there, it'll be groups to discuss, how they do that. For those of you who have been part of my pre-myectomy calls over the years, there's a lot of them, and I can't do one-on-ones anymore, so we're going to be doing them in a group meeting. So rather than handling one-offs, we're going to be handling 10, 15 at a time and giving you an opportunity to ask questions in the support group. There'll be also a teens through 25 group that'll be moderated by myself and a few younger people. And it's going to be a great way to get everybody to really understand HCM and feel connected and supported. We're also starting our peer-to-peer Bighearted Friends group. This will launch at the end of the 4th quarter. So we're going to train mentor and mentee peers, so that you'll be able to do an eHarmony type question and answer, whether you want to be a mentor or you're looking to be matched with a mentor. And we'll try to match up people who are looking for the same experiences. They want to talk to somebody who's had a myectomy. They want to talk to somebody who has atrial fibrillation, or somebody's been on a particular medication. We can link them together and they can help each other out. So it can be one call, it can be a month of communication, or it could be a lifetime friendship. You don't have to make any time commitments to this if you want to volunteer. And you'll always have the support of the office. We also have our new podcast system, which is we're going to use this for a few things, including our Share Your Story segments. So if you have HCM and you want to share your story and help others understand HCM better, you can sign up for a Share Your Story session. The Share Your Story sessions will be video and audio, and they'll be used on our upcoming brand new website, hopefully out Q1 of next year. And we will be using your segments from Tales from the Heart. We'll be using video. Like I said, you can submit pictures, video. We're going to put these snippets together like the PFDD, if you saw that. We're going to be using those types of elements. And I have, I put something out of order. I'm going to talk more about Tales from the Heart in a moment and some upcoming events that are going to be really cool. I do want to talk about the kickoff of the Elizabeth T. McNamee Legislative Subcommittee, which we named last fall, actually last October. And we've taken the past year to organize a strategy and create a template as to how we want to change legislation in the future. We are working towards state level legislation to improve the well child examination to include the same components as the pre-participation screening physical for athletes. And we have sample legislation written up. We have all of our facts in order, and we're going to start training people after November 4th because people are very tied up, those who are interested in legislative action. They're looking at the national level right now, so we're going to let that pass. We're going to train them up on how to do state level advocacy here. We also will support any good CPR and AED legislation and Good Samaritan coverage for using either AED or CPR in the public. We want to, on the federal level, support health insurance for pre-existing conditions. We will work with the FDA, CDC, and other related agencies as it relates to drug discovery, patient safety, or other items that might be of interest to the HCMA community. And if you want to sign up for the legislative subcommittee, you're going to be getting a survey after this meeting, which will give you an opportunity to sign up so that you can get on our training list and hopefully join us for 2021 to start literally changing the world through legislation. If you have not viewed it yet, the PFDD, the Patient-Focused Drug Development Meeting, oops, that's going to actually start on my other window here. Sorry about that. Is available online still. You can still make comments on it. You can see the videos that we've done there on patient stories and experiences. They will be plugged into the website soon as well. But you can see what we did talking to the FDA, and literally sitting here on my desk in my office is the Voice of the Patient report, which will be submitted to the FDA and will become the guidance for drug discovery and device discovery in the HCM field, hopefully for the next 15 to 20 years. So it's a really important document. It's a really important meeting. And thanks to all the patients who participated in that one. Oops. Uh-oh. Something happened. Oh, it's trying to make me click on this. Oh, there we go. There we go. I told you at the beginning of my talk that we have a free genetic testing program through Invitae. Oh, I have to go back up to a slide because I went through something pretty quickly. Sorry, but I'll do that in a second. Invitae, who's one of the sponsors of this meeting tour, they have an amazing program where if you want genetic testing, you can get genetic testing. There's a link at forhcm.org. You can just take it right to this testing panel and you can get free genetic testing. All you need to do is have a physician order it and the test can get done free of charge. And any member of your family is welcome to use the program as well. I would encourage you to use it quickly because you never know how long these things are going to last. They are sponsored by the drug industry. As you saw in the beginning, I said there's some diseases that have particular treatments associated with them that are genetic in origin. Obviously, those companies have a vested interest in finding the right patients so that they can give them the right therapeutics. So that's where this is getting paid for from. There is no fee to the patient, no fee to the hospital or ordering physician. So this is what I thought was in a different part in my slides. So Tales from the Heart is going to have a special co-host for the rest of this year. We have 3 segments set up with Dr. Harry Lever. We're going to be discussing different topics and diving into some interesting conversations as we have in the past. I'll talk more about that later in tonight's meeting. But I encourage you to sign up. You can register through Facebook. They're free sessions. Just sign up so you know when they're coming. And I'm going to almost end there. I'm going to make y'all dizzy for a second because I have to flip back here because my slides messed up in the beginning. I need to acknowledge our wonderful sponsors. Myocardia, Cytokinetics, Boston Scientific, and Invitae have provided financial support of this meeting, which was originally supposed to be in person, but unfortunately COVID hit and we are all sitting at our desks. So I want to thank our partners at Cleveland Clinic, not Scripps, my typo error there, to all our HCMA recognized centers of excellence, our staff who have been amazing putting these meetings together. It looks easy to throw a webinar, but to get everybody together, pick the date, do the marketing, do the time, it's a lot. To all of our HCMA volunteers, some of them who are online tonight, And I wanted to also always thank Brandy and her family. Brandy was my organ donor, and her family made the decision that helped me be here today. So sign your organ donor cards. And with that, I'm going to stop sharing my screen and hand it back to Malind.
Thank you, Lisa. That was excellent. I am going to share my screen. Can you see this, guys?
We can see it.
All right, thank you. So without further ado, I'm going to get to my talk and the rest of the clinical folks' talk. So as I told you earlier, I'm gonna take a futuristic view and talk about what is new things happening in treatment and risk stratification as it relates to hypertrophic cardiomyopathy. I have no financial disclosures, but I am on the steering committee of a hypertrophic cardiomyopathy trial sponsored by NIH. You're going to hear about it a lot in the next few years. And I'm also the national principal investigator of a new trial, Valor HCM, which is sponsored by Myocardia. It is already enrolling. So without further ado, let me see what I need to do. Hang on. So there you go. HCM Center at the Cleveland Clinic. This is a team sport. Anything that we do in medicine is a team sport. And clearly, we have a very, very good team. No question about it. This is just the last 3 years. Total HCM visits, more than 4,000 patients. New patients, more than 750 patients. And we are growing. And it is testament to the hard work put in by a lot of team players here, 3 of whom are already on this program. Our surgical volume, last year we did more than 200 myectomies. That number is one of the largest on the planet as it stands. So, give credit where credit is due. In our successful pursuit of HCM, I cannot state it in anything but simple terms. We do stand on the shoulders of a giant. Harry, Dr. Lever, as all of you know him very well. He's been here since, I think I'm gonna tell you, Harry, I think you started here when I was in first grade, hands down. But as of August 2020, Harry has transitioned into his new role. He's not actively seeing patients or doing active clinical work. He will continue to serve as a consultant for the Cleveland Clinic. He remains, in my opinion, our guiding light. And what is his legacy as we look back? He has established a solid foundation of HCM cardiologists, many of whom he has helped train. He's worked closely with interventional cardiologists, EP doctors, geneticists, surgeons, mental health folks. We have created a superb team, and a lot of credit goes to Harry for this. This is our team, and I could not put all the pictures here, but as Lisa alluded to, we have a cadre of HCM specialists, hocomologists for the lack of a better term, 2 interventional cardiologists. I think we are growing there. Nick, Dr. Smedera, and Per Vierup are our 2 superb heart surgeons who are masters of their craft. And, the shining light behind all of it still remains Harry, without a doubt. So what are the objectives today for our HCM Center? As I told you, we will be talking about newer concepts, not just surgery, a little bit about exercise, living life, risk stratification, what is down the pike in genetics, and there's a lot of chatter as it relates to newer drugs. We will talk briefly about that. So, talking about surgery, as has been alluded to, one operation does not fit all. You will be hearing more about it from Dr. Smedera. We at the Cleveland Clinic emphasize that it's not just a myectomy that fixes the problem. If you have HOCM, obstructive cardiomyopathy, most patients, they may benefit from a standard myectomy. We have identified many subgroups where we have to get creative. Necessity is the mother of invention. So we do a lot of concomitant mitral valve or papillary muscle surgeries. Dr. Smadira will be talking about it a little bit more. At the Cleveland Clinic, we also started doing apical myectomies without burying a hole in your apex. We at the Cleveland Clinic believe that apex should be left alone without a hole. This cartoon here shows these are all our patients with HCM. The blue is a simple myectomy. Everything else, so we do more complex surgery. We do more things to relieve HCM obstruction than a simple myectomy. Is there a case to be made for an earlier operation? This paper actually just got accepted last week, just in time for this conference. More than 2,000 surgical myectomies, surgeries from 2002 to 2018. What the paper has shown, if you wait for a class 1 indication, meaning if you wait for advanced symptoms, versus do an earlier operation, basically your outcomes with an earlier operation are much better and very similar to an age and gender matched United States population. The cartoon on the right shows that at the experience center like Cleveland Clinic, doing a myectomy or a myectomy plus mitral valve procedure, they are one and the same, essentially the outcomes, long-term. These are not 30-day outcomes. These are long-term outcomes. They are very similar. So experience matters. And if you are in the right center with the right team, your outcomes are similar to age and gender matched normal population after surgery. That's a big deal. Keep that in mind. We are pushing the envelope because this is the Cleveland Clinic. Our colleague, Dr. Pierre Vera, brought with him some talents at robotic mitral valve repair, and he's trying to incorporate that in the context of myectomy. So if you could, down the road, amongst a few other things, if there's a younger person, we may be able to do a myectomy with a scar that looks like this, a small scar on the right side of the heart, where you can do a mitral valve repair and a myectomy, and you're home on day 3, day 4. Again, this is works in progress, but more to come in the foreseeable future. As Lisa alluded to, experience matters. Absolutely 100% experience matters. Our post-op mortality at the Cleveland Clinic is close to 0%. National data suggests it can reach up to 6%. Low mortality at a place like Cleveland Clinic does not occur by accident. Look at the number of cases, number of centers that have more than 100 cases on the right. There's very few. And experience, we are what we repeatedly do. And that's why excellence is not an art, but it becomes a habit. It is a habit. It is not a slick operation. It is a habit. What are some of the newer concepts in diagnosis and risk stratification? So as has been alluded to, multimodality imaging is key. Do what it takes to precisely characterize the patients. And it may involve echo, stress echo, MRI, in some cases TE. You may need cath lab assessments. Risk stratification, this is getting into the weeds, but suffice to say there are 2 thoughts, one in North America, one in Europe, where they approach risk stratification in slightly different ways, and they feel passionate about one versus the other. But be it as it may, family history of sudden cardiac death, very thick heart, passing out without any reason, non-sustained arrhythmias, scar on your MRI, burnt out hypertrophic cardiomyopathy, or apical aneurysm where the bottom of your heart has blown out. These are some of the known risk factors, and you can count the risk factors, or you can calculate a fancy formula to decide about putting an ICD. Be it as it may, in the experienced hands, risk stratification works very well, and your long-term outcomes are very similar to an age and gender matched population. So some of the data. So the American approach suggests that the number needed to prevent one cardiac death is about 6.6, versus the European approach where the number needed to treat is 10.3. So the argument may be that the American approach may be better off, more sensitive, and prevent more sudden cardiac deaths. Be it as it may, both of them are well used and people are passionate about both those on either side of the Atlantic. We have shown, this is almost 2,000 patients, that surgical myectomy may mitigate the risk independent of what your score is. Your risk of sudden cardiac death may be mitigated by surgical myectomy. More data will emerge as the years go on. But this is crucial. If you have surgical myectomy, potentially we may be also altering your risk of preventive sudden cardiac death. Newer things, MRI, I'm sure many of you have had MRIs done for HCM, and this is the paper that we published. There's multiple other publications which have shown higher the amount of scar, the worse your outcomes are. And this may well become a risk stratifier to put an ICD. Some of the newer stuff, there's a fancy echo technique newer thing that we are doing called strain assessment. So this measures the contractility of the heart better. It is an advanced marker. And again, this is data that we have shown where strain could potentially have a role in risk stratification of hypertrophic cardiomyopathy. I alluded to the NIH trial. This is the first paper that was published last year. This is almost 3,000 patients across 44 sites in USA, North America, and Europe. And lots of data is going to come out of this. This is under evaluation and statistical analysis as we speak. But you are going to hear about this a lot more as the years go on. Exercise, sports, and living life. Basically, some of the data that is coming out recently. This is paper predominantly from Michigan, published a couple of years ago, where people have shown that moderate aerobic activity may be beneficial. So just because you have HCM or HOCM doesn't mean you stop exercising and become a couch potato. In fact, this may be better for your heart, being moderately aerobically active. This is a busy slide. I put in just last week, the Europeans have published their sports recommendations for various heart diseases. And they have divided exercise into high, medium, and low intensity exercise. I don't know what style dancing is. It caught my attention, so I highlighted. But be it as it may, there are some recommendations. There's not much data, okay? A lot of these are recommendations based on people's opinions. And bottom line is, your HCM specialist or your sports cardiologist is the right person to be having these conversations with. And especially if you are an elite athlete just recently diagnosed with HCM, it is crucial that you seek one out. Thrill-seeking. I found this paper very interesting. Thrill-seeking activities and HCM. Almost 700 patients, 11 activities, roller coaster, paragliding, kayaking, base jumping. Holy cow, who does base jumping? What they showed in this paper was 9% patients reported a major event within 1 hour, and 8 participants reported a major event within the same day. I'm not insinuating you go base jumping, but this is published just last year. There is a study, Live HCM, that should also further help shed light on exercise capacity. You know why I found this paper interesting? One of the co-authors is Lisa. Look at that, Lisa Solberg. So anyway, moving on to what are we doing? We've named we have an ongoing study, almost 175 patients. Some of you may have participated in it, Spirit HCM. These folks underwent surgical myectomy at the Cleveland Clinic, and we are doing a quality of life study. Believe it or not, we do not have real tangible data. The enrollment is complete. We are in a follow-up stage. We should have the results in early part of 2021. One of my students, Sammy and Barb, many of you may know either or both of them, they are working on another quality of life study of HCM patients who are not sick enough, advanced enough to need surgery. So we plan to enroll almost 500 patients. We have enrolled 150 plus patients already, despite the COVID situation. So more data. I think it is important for us to know in terms of what happens in terms of quality of life. Genetics, crucial, lots of data going on. Share registry, Caroline Ho at Boston is leading this. Again, lots and lots of stuff are gonna come out as the years go by. Gene editing. This is like a couple of years ago, it was published, it made a lot of news. This is still very early on, but embryonic modulation to cure HCM at the embryonic stage. I mean, this is where the future is going. So this is something cool. Hopefully it pans out, and we could have a whole different conversation downstream. Newer therapies, I'm sure a lot of you have heard about the emerging drugs. We are truly entering into the era of novel therapies that directly impact survival, not survival, but symptoms and exercise capacity. I'm sure many of you have heard mavacamten, which is a first-in-class. It basically reduces the hypercontractility of your diseased HCM muscle. And there is a series of studies that are ongoing, and some of them have been published. Many of you may have taken part in these studies. The Pioneer HCM, which showed a significant reduction in outflow tract gradient without a reduction in ejection fraction. Recently, another study, a Maverick HCM, that was published in non-obstructive HCM patients, showing a slight improvement in functional capacity. Last week, Explorer HCM was a phase 3 randomized study in obstructive HCM patients, which was just recently published, which basically suggested that there is improvement in your functional capacity or NYHA class in a significant proportion of patients. And it resulted in a substantial reduction in your outflow tract gradient without any significant impact on your ejection fraction. So exciting times ahead. Valor HCM, you're going to hear about it. We are running this C5, so Cleveland Clinic Research Arm is helping run this. Barb is my research coordinator. I am the national principal investigator. This is being run out of 15 trials in the United States on patients who are candidates for heart surgery or alcohol septal ablation. We want to see if we can help modulate the need for such advanced therapies. Another drug manufactured by Cytokinetics is also being tested in what is known as the Redwood HCM trial. So a lot of new stuff is happening. A lot of new stuff is happening. So what is the future of HCM Center at the Cleveland Clinic? Pushing the envelope of research and innovation. It is our plan to start an HCM fellowship. It is my commitment once the COVID situation is done, I want to start a Harry Lever lectureship. And legacy is defined by future leaders, what you bring to the table in terms of training the future. I mean, these are some of the folks that are working with us, and there are many more that are part of the team. What is in it for me? What is my motivation? The guy on the left, he was one of my closest friends growing up. The second one from the left is my younger brother. This is the guy on the left's older sister, and this is me. Promise you, I'm not picking my nose. I'm just biting my nail. This guy died at the age of 31 years of age, leaving a wife and 2 kids behind from hypertrophic cardiomyopathy. It's not because of lack of resources, but he got bad medical advice. I do not want to live through another phone call like that. I do not want to live through another phone call like that. So, conclusions, I think the future is bright on many, many fronts. As I said, none of this would be possible without the central component of it all, you, the patient. So I truly thank you from the bottom of my heart on behalf of the team. Dream big, desire to evolve and drive the change. Leading is simply that easy and just as difficult. I thank you so much for your attention, and I think I will hand over the mic to Harry. Dr. Lever.
Actually, I'm going to take the mic for a moment first. So we're going to have you stop sharing your screen. And I'm going to go back to sharing my screen because I'm going to introduce Harry.
Okay.
Okay, so Harry, you'll be up in just a second. But I have to take the opportunity to explain that I am like part of the Harry Liver Fan Club. Didn't know it was actually a club, but it's really a club, and it's an important club. 24 years ago, some of the very first phone calls I made, and the notes are in a binder right on the other side of my desk. I spoke to a guy named Barry Marin. I spoke to some guy named Bill McKenna out of England. I spoke to Cricket Seidman. I spoke to Mark Sherrod, and I spoke to Harry Lever and said, what do we need to do as a community to come together? And each of them gave me their point of view from a very specific point of view. Harry's point right up front was, we got to help these patients. Others might have been interested a little bit more in science and research and what don't we know, but Harry was right there with, we have to help these patients. I know there's more out there. I know there are. I said, well, how many myectomies do you guys do a year? About 20. I'm like, okay, that's awesome. Because like nobody else is doing that much except for you and Mayo. They're both doing about the same amount at that point. So about 10 years ago, Harry embarrassed the hell out of me at a meeting by putting up a slide that had what he called the Lisa factor. I said, could you please change that to the HCMA factor? And it shows that when we started working together in 96, this myectomy volume went up. Now, when you're looking at it from the Cleveland Clinic's point of view or a hospital's point of view, yay, more surgeries. But when you're looking at it from our point of view as the patients, we finally found somebody who could guide us to proper care and get the therapies that were not available elsewhere. And Harry was right there with me, step by step, day by day, thousands of phone call hours later, helping guide these patients. He was our first HCMA clinician of the year. And just this year, while we're all in COVID times and locked in, he got online with me on technology that's not exactly something that's second nature to him. And we did two talks. One was a presentation Harry gave on generic drugs. And then we brought in the author, Catherine Ebon, who wrote the book Bottle of Lies, and we interviewed her collectively. And between those two events, we had over 15,000 views of his content. He's compassionate, he's caring, he's connected, and I consider him one of my dearest friends. So, Harry, it's on you now, babe. Share your screen.
Thank you very much. Can you see it?
We got it. Put it in present mode, and you'll be good.
1 second. Got it?
Got it.
Okay, well, we're going to talk about pearls and the diagnosis and decision-making for hypertrophic cardiomyopathy. And the first thing we want to talk about is the symptoms that occur in this disease. And we have to understand that this is the result of outflow tract, in many cases, outflow tract obstruction. And what we're looking at in hypertrophic cardiomyopathy is the hypertrophy that occurs below the aortic valve. And that's what contributes with the mitral valve to cause outflow tract obstruction. This is the aortic valve here, and you can get aortic stenosis here, or actually you can get a membrane below the valve, or you can get obstruction at the valve, or you can have supravalvular obstruction. But what we're going to concern ourselves with is below the valve. And the symptoms are typically shortness of breath, chest pain, palpitations, syncope or dizziness, and then, as has been said, some sudden death. There may be asymptomatic presentations where you just hear somebody hears a heart murmur, or unexplained left ventricular hypertrophy with or without a murmur, or an electrocardiogram that looks like an old heart attack. Now, when we do a physical examination, it's very important that we do physical examinations, because you can make the diagnosis sometimes of the disease just by feeling the carotid pulse. Sometimes there's this double pulsation, and you can have an idea that that's what we're dealing with just by palpating the pulse. Then you can feel the apex, that it's very strong, and a systolic murmur. Now, when you come to see somebody for this diagnosis, we put you through some maneuvers. One is called the Valsalva maneuver, where we have you bear down. And what that does is that reduces the size of the left ventricle, and it causes the obstruction to become greater, and the murmur increases. And then, of course, when I was trained years ago, we used a lot of what we call amyl nitrite, which is an inhaled form of nitroglycerin. And it goes away very quickly, but it's very helpful because it also dilates the peripheral blood vessels, causes the ventricle to decrease, the murmur increases, and the gradient increases. In the operating room, we use a drug called isoproterenol so that after Nick is done, we make sure that there's no longer any outflow tract obstruction. Now, let's talk about Brock's disease versus Tears disease. Dr. Brock was a surgeon many years ago who, when he went to the operating room with a patient, he found that he thought that there was aortic stenosis, but he found that there was very severe hypertrophy below the valve and didn't know what to do for the patient, and the patient died. Tears disease was, Donald Tear was a pathologist in England, and he was the one that described the very severe hypertrophy. The question is, are we dealing with a congenital disease or an acquired disease? This is a young patient here with very severe hypertrophy and obstruction to the blood flow, which we call systolic anterior motion, which we'll get into in a minute, versus an elderly 93-year-old patient who has obstruction to the blood flow, but only very localized hypertrophy. And this is that young patient, again, very severe hypertrophy of the septum here, and then systolic anterior motion again, and then this only very localized hypertrophy. And I was fortunate to work with a very bright woman, Bernadine Healy, and we wrote this paper a number of years ago where we looked at the difference between elderly and young patients by echo, and we found that the elderly patient had a high incidence of ovoid left ventricles, whereas the young had reversal of septal curvature, but the elderly had this very curious proximal septal hypertrophy, and the young people had very severe right ventricular hypertrophy as well. And there was, of course, more calcification in the mitral annulus. And so we said that the elderly had ovoid shaped, normal curvature, low incidence of RVH, high incidence of proximal septal hypertrophy, and a high incidence of calcification around the mitral valve, whereas the young had a crescent-shaped left ventricle, reversal of septal curvature, high incidence of RVH, but no proximal septal hypertrophy. And this is what this is the normal heart. This is what we saw in the tended to be the normal shape in elderly versus and this type in elderly versus this is was the young type. And we said that the clinical signs and symptoms of hypertrophic cardiomyopathy in the elderly and young were similar, but the structure of the heart in hypertrophic cardiomyopathy of the elderly was different than that seen in hypertrophic cardiomyopathy of the young, suggesting that we were dealing with two distinct diseases that may have differing pathophysiology and natural history. And we were fortunate that the Mayo Clinic also looked at it a little differently. They looked at the genetic makeup, and they found, interestingly, that the young type had a much higher incidence of positive genes in this reversal of septal curvature that we see here, versus with the proximal bulge that we saw in the elderly, only 8% were gene positive. So clearly the young type tends to be more gene positive inherited disease, where this is acquired disease that occurs in young people, maybe, or in old people rather, related to the development of hypertension or something of that sort, or just natural aging and the proximal portion of the heart hypertrophies. So let's talk a little bit more about physiology. And there is resting obstruction, latent obstruction, or no obstruction. And there was a study a number of years ago by Dr. Marty Marin. He looked at 221 patients. He found no obstruction in 29.4% of patients, 41.2% had resting obstruction, 29.4% had provocable obstruction. And when we looked at the whole group, 70.6 had resting or provocable obstruction. So it's very important when we look at patients that we make certain that there is evidence for obstruction, either resting or provocable. And we were one of the early groups that recognized that provocable obstruction in many cases needed surgery, that with stress testing, we would see high gradients with exercise that you wouldn't see at rest. And that's very important that we look for that. Now, hypertrophic cardiomyopathy is not just a thick septum. The syndrome, we call it a syndrome of outflow tract obstruction, or as Dr. Desai taught me, OCM was what we called it. Oops, let's go back. Now, let's look at anatomy and physiology. And when we look at the anatomy, we have to look at the muscle, the ventricular muscle itself, the papillary muscles, the chordae tendineae, which are the structures that are attaching the mitral valve to the papillary muscles, which we'll show you some diagrams, and then the mitral valve. And hypertrophic cardiomyopathy is a complex interaction of the mitral valve, the papillary muscles, the chordae tendineae, the ventricular septum that causes obstruction and even mitral regurgitation. So when we look at the ventricular muscle, we want to know, is there hypertrophy present or is there none? And as a matter of fact, we recognized after a number of years that there were patients who could develop severe obstruction to the blood flow out of the heart and have no hypertrophy at all. And we were lucky that our Dr. Cosgrove, one of our head of our surgical department for a number of years, recognized how to repair mitral valves, and he taught us a lot about that. And then we were able to take that to the problem of these patients with severe obstruction, and or rather no obstruction and severe no hypertrophy and severe obstruction. So you can have hypertrophy of the proximal septum, hypertrophy of the whole septum. You can have concentric hypertrophy, even just lateral wall hypertrophy, or apical hypertrophy. When we look at the mitral leaflets, we want to know the size of the leaflets. Are they both normal? Is the anterior leaflet large or the posterior leaflet large? And on occasion, both leaflets can be large. Now, when we look at the papillary muscles, and we'll show you what those structures are. We need to know the number of them, where they are located, medial, lateral, or apically located. We've had how many heads of these papillary muscles are there? What size are they? And how strong are they? Are they able to anchor the mitral valve? Papillary muscles may sometimes be directly attached to the leaflets. There may be anterior or apical displacement of these papillary muscles, which we'll show you in some diagrams, or they may even be attached to the septum. Now, we talk about systolic anterior motion of the mitral valve. That's when the mitral valve hits the septum and causes outflow tract obstruction, and the degree of mitral regurgitation is related to leaflet length. We also look at the direction of the jet. If it's SAM related, it tends to be what we call posterolateral, and we'll show you a couple of those. You can have a flail leaflet where the leaflet actually tears and the mitral valve has to be repaired. Or you get this calcified mitral annulus, where there's no contraction of the annulus and you get central mitral regurgitation. Now, the mitral valve is like a sail in the wind. Sails here, and how those leaflets tend to move based on how the flow of the blood is and how long the mitral leaflets are, how large they are. If the leaflet, and what do we need for outflow for SAM to cause the outflow tract obstruction? We need anterior position of the coaptation point. We need a positive angle between the outflow and the protruding leaflet here. And then we need some slack in these what we call the chordae tendineae. Now let's look at the anatomic spectrum that we're talking about. This is a normal heart, normal septum, normal position of the papillary muscles, and normal mitral leaflets. This is a cartoon of how the mitral valve works. Here, these are the papillary muscles. These are the chordae that attach the papillary muscles to the mitral leaflets. This is the posterior leaflet, this is the anterior leaflet, and this is the aortic valve. In this particular diagram, there is no leakage of the mitral valve. Next is the classic hypertrophic cardiomyopathy with a thick septum, normal mitral valve, normal papillary muscles, and these are the chordae tendineae that attach the papillary muscles to the leaflets. This is the left atrium here. Here is a cartoon showing how the mitral valve obstructs the blood flow out of the heart as it contracts right here. Mitral valve comes over, hits the septum. The septum is thickened here. We get accelerated flow here and some leakage of the mitral valve. And depending on the case, there can be a lot of leakage or no leakage. There's a wide spectrum, just depending on how everything fits together. And these are the papillary muscles down here. Next, we can have a thick septum, a long anterior leaflet, and normal papillary muscle. And in this situation, what we have to do sometimes is remove some of the muscle. And then after that, if there's still problems with obstruction, sometimes we've got to shorten this anterior leaflet right in this area. We would take some of that away. And Nick will tell you a little bit more about that. Here we have a situation where it's thickened muscle, normal leaflets, and apically displaced papillary muscles. Here we have a situation where there are only apically displaced papillary muscles, normal leaflet, and normal septum. And here again, we have to sometimes make some manipulation of these papillary muscles to get rid of the obstruction. Next is one where there is only a long anterior leaflet, no septal hypertrophy, papillary muscles are normal, and if there's significant obstruction here, the surgeon will operate on this mitral valve, and there are numbers of procedures that can be done to shorten it, to get that out of the way, and we don't even have to do anything to the muscle. Here is another cartoon where we see there is the anterior motion of the mitral valve. There's some leakage of the valve here, and there's no hypertrophy. So this is the cartoon of the slide before where there's no hypertrophy at all, and something has to be done to the mitral valve. Here we have all three. We have hypertrophy of the septum, elongated anterior leaflet, apically displaced papillary muscles. And then depending on how things go, there may be numbers of things we have to do here. And we use the echocardiogram, transesophageal echocardiogram, to guide us in the operating room to know, to see how things are going before we close the patient. And we know by the time the patient leaves the operating room that they're fixed. Here we have one with an apically displaced papillary muscle and thickened apically displaced papillary muscle and a thickened septum. Okay, and then there's a way where you might just move that papillary muscle and get the mitral valve out of the way. Here we have normal septum, elongated anterior leaflet, and apically displaced papillary muscle. Next is bifurcated papillary muscles with a normal septum and still getting outflow tract obstruction. And sometimes we have to sew these papillary muscles together and move the valve down. Here's another one with bifurcated papillary muscles, thick septum, normal mitral leaflets. Let's keep going. Now let's quickly look at a couple of cases. This was a 45-year-old woman with a family history of sudden death. She had complaints of fatigue and shortness of breath. She was gene positive for the myosin binding protein C3 gene, and she already had the AICD. Okay, here we have a situation where she's got a double head, what we call bifid papillary muscle. There's obstruction to the blood flow here. When we did the Valsalva maneuver where she bared down, like we talked about earlier, she developed severe outflow tract obstruction with a gradient of 88 millimeters of mercury. Here is the septal measurement of 27 millimeters. And here again, we see the severe systolic anterior motion of the valve here. And this patient would probably require working on the papillary muscles and removing some of the muscle. Oops, let's keep going. 27 millimeter septum. And she had the novel gene. Okay, now the next is a very interesting case that I think Dr. Smadira will remember. This is a 50-year-old gentleman who 4 years ago had the sudden increase in heart rate with dizziness, and an echocardiogram was on the outside inconclusive. Early in 2016, watching a debate, he suddenly noted racing of his heart and lost consciousness. Lord only knows what he would have done today. What's going on? A Holter monitor revealed an episode of ventricular tachycardia with a rate of 207 beats per minute. Stress echocardiogram revealed an increase in outflow tract gradient and a drop in blood pressure. He had already had his ICD placed when he came to see us. Now, the interesting thing to note is here, he essentially has no hypertrophy of the septum. And there's minimal motion of the mitral valve towards the septum. And what you look at, it's a little more difficult to see on this view, but this papillary muscle is attached into the body of the mitral valve right there. But we'll see that better in a second. Whoop, sorry. Now, we gave him this amyl nitrite, and what we saw was he had severe obstruction to the blood flow. The mitral valve came over and really hit the septum. But again, notice there is no hypertrophy. When we gave him amyl nitrite, we measured a gradient of 98 millimeters of mercury, which is very high. He had no hypertrophy, still was able to get a gradient of 98 millimeters of mercury. We did a transesophageal echocardiogram, and then we found lots of stuff. We find here that this papillary muscle, which is attached almost into the body of the leaflet right here, but we see it better here. He also had posterior leaflet prolapse. So he had something wrong with the posterior leaflet. He had this papillary muscle that was attached into the body of the leaflet and essentially no hypertrophy. Let's go to the next one. And he, whoops, went the wrong way, sorry. Here, he's got actually prolapse of both leaflets in that view. So we did a stress echocardiogram on him, and he developed severe obstruction again, just like with the amyl nitrite. The gradient went up to 221 millimeters of mercury. And mind you, again, no hypertrophy. So post-operatively, we find that we gave him amyl nitrite. He had no evidence for obstruction and no mitral regurgitation. When the surgery was done, the mitral valve was repaired. The papillary muscle was detached and reconfigured, and there was no septal myectomy done on this patient. One last case is a patient with mitral leaflet abnormalities, 51-year-old gentleman with stress-related chest pain, shortness of breath, and palpitations. His electrocardiogram was absolutely normal. And here we have, he's got anterior leaflet SAM, see the mitral valve moving and hitting the septum, and he's got posterior leaflet prolapse here with some hypertrophy, not severe. And one, let's see here. And here, again, the mitral regurgitation is what we call anteriorly directed. When we went ahead and gave him amyl nitrite here, he got severe obstruction to the blood flow right here. There is some prolapse, but interestingly, the direction of the jet was now posterior lateral. We changed the jet direction by causing more severe obstruction, and he had a myectomy, but mainly a mitral valve repair. So in summary, hypertrophic cardiomyopathy has a broad spectrum. This is a problem of geometry. There are varying variety of locations and severity of hypertrophy, varying sizes and of mitral leaflets and varying severity of mitral regurgitation. Papillary muscles can have different locations and orientation. There are multiple heads, and there may be direct attachment of the papillary muscle to the leaflet, and you can have resting, latent, or no obstruction. Hypertrophic cardiomyopathy is a complex disease that requires a clear understanding of all the anatomic variables before the symptomatic patient can be successfully intervened on. Thank you very much.
Thank you, Harry. I'm going to say wow, when I talk about the differences in anatomy and when you talk about understanding everybody's individual HCM, you've just laid it out so beautifully that there are so many different anatomies that can come up. And I know that so many of you, when you call the HCMA office, when we go over your records, you think, well, it's all just HCM, right? No, you just clearly laid out, it's not all just HCM. It has so many nuances. So I'm going to introduce our next speaker in a moment, and we'll do, there's a lot of questions that are coming into the Q&A field. So what we're going to do is, I know Dr. Desai has been answering them. Thank you very much as they come in. But we're going to read them all out loud at the end so that they get on the tape so people can see what was being said behind the scenes, so we can answer those questions. But I am going to show my screen again because I have to introduce Nick in a certain way. So I know this doesn't seem to make a lot of sense, but I chose these two pictures, and it's my dad and I. And from an HCM perspective, I'm going to tell you the picture of the girl in the wedding dress is actually me. And within 12 days of that picture, I had my first signs of endocarditis. And within 3 weeks of that picture, I had a stroke. And I'm here today to tell the tale. And that was my dad back in 1990. The second picture is only possible because my father met Nick Madeira. This was almost a year after his open heart surgery. He did not have a myectomy. Dad needed a mitral valve replacement, and we thought maybe a little bit more. I will never forget the call from Nick. I'm in the lobby listening to the phone. He's like, okay, Lisa, get a pen. This is what we did. Mitral valve replacement, tricuspid valve repair, right-sided maze, left-sided maze, right atrial reduction, left atrial reduction, and a cabbage. And my dad survived. Had my dad not met Nick Madeira, I wouldn't have had that lovely day with him on the boat and the extra 2 years we got with him. So Nick, thank you very much for that. And there's a reason that we refer to you as Saint Nick, because you have changed many lives with your very gifted hands. And I hand this talk over to you.
Oh, thank you so much. That was touching. That was really moving. Well, hello, everybody. Good evening. I know we're a little behind, and I want to give Betsy a chance. So I hope you're all staying safe. And, my thoughts go out to all of you and anybody. I saw we had some on the West Coast and some from the South. And I know we've had the hurricanes and the fires. I hope you're doing well. A lot of this has been teed up by my colleagues who I've had the great honor of working with for the past 20, 25 years. I've learned so much from Malin and especially Harry. We share a lot of thoughts as we struggle taking care of patients, trying to figure out what we should do. And Harry brought this out, Malin brought this out. This is one of my favorite anatomy books. And you've seen these pictures in different ways. But I try as a surgeon to simplify things into a very simple way of thinking through things. And I think of the heart as a pump, and out here's the aorta, the pipe. So you got a pump and a pipe, and you got a space, the outflow tract where the blood has to go through. And one side's the septum, one side's the valve. And if those two get too close, you have an obstruction, and the blood has to go somewhere. So if it can't get out, it's got to go backwards. So it goes into the left atrium, which is into the lungs, and you get shorter breath. And if you really can't get out, you get dizzy and you pass out. And it's really that simple. And over the course of my practice, the thing that kept coming up that we got so fixed on and it didn't make sense because it's hypertrophic cardiomyopathy is, how do you explain the patients that have this obstruction who don't have thickness? Because it's always hypertrophic cardiomyopathy. And so it was simply said, we don't know. We cut out the valve, put an artificial valve in, and you cure the problem. But it didn't really force us to understand the problem. And I think that's what I have really spent a lot of time thinking about over the years is, why does that occur? I always like to go back and think of, how did we get where we are? And I'm always fascinated by the history of surgery. And this is an amazing picture of how they did one of the first type of myectomies. That's why people call it myotomies, the septal myotomy. Myotomy just means a cut. And before we had good ways to protect the heart and the safe heart lung machines, the surgeons would develop what would look like a thimble, and they put the thimble on the end of their finger, and on the end of the thimble was a knife blade. And then you can see it here in the picture, the finger, here's the tip of the finger, and here's this knife blade that's actually attached as part of, that's the instrument itself. And you'd go in as quickly as possible and you'd make a slit with the knife blade. And then you take your finger and you'd crack the muscle and you'd just make a big rent in it to open it up. And you can see how thick this illustrator put the muscles. It was barely any chamber at all. And this was back in 1961. So that's where we started. And that's where the focus on hypertrophy was. They didn't have the imaging studies that Harry and Melinda just showed you. It was the by exam, and this was the best you had. Morrow described the first myectomy, and this is where you make a cut, and I'll show you a nice video. And the alternative, as Dr. Lever talked about, was, well, you can also get rid of that obstruction if you get rid of the valve. And here's a mechanical valve. And the Houston group, the Methodist group, and Denton, Cooley, and DeBakey, they preferred replacing the mitral valve rather than cutting out muscle. But this left the patient needing lifelong anticoagulation with Coumadin. And we always focused on preserving the patient's valve. And as Lisa mentioned, it reduced the risk of you having endocarditis if you didn't have an artificial valve. So that was how we approached things. So we started with a sort of rectangular piece. I tell patients that it's sort of like the sashimi you see in the store, in the restaurant. I cut it out just like a rectangular piece. I expanded it to a much bigger square or rectangle because we recognized the hypertrophy went well into the depth of the ventricle, and you had to go extensively from side to side. That simple rectangle just wasn't sufficient enough in most patients to eliminate the obstruction. And here I want to show you a video. It's narrated by one of my fellows. And this is just about in real time.
This video demonstrates the surgical technique for extended septal myectomy. Here, the heart has been arrested with integrated donatocardioplasia and a transverse aortotomy has been made above the level of the sinotubular junction. 3 stay sutures have been placed in the aorta to facilitate exposure. The aortic valve, septum, anterior mitral leaflet, and subvalvular apparatus are thoroughly inspected. The myectomy is performed according to a 3-step approach based on the location of leaflet septal contact identified on transesophageal echocardiogram. This contact is commonly 18 to 22 millimeters below the nadir of the right coronary cusp. At this point, 2 parallel incisions are made 10 millimeters apart, 5 millimeters deep, and 15 to 20 millimeters long with an inverted number 10 blade. These incisions are connected using a number 15 blade, and a rectangle of muscle is excised. The edge of this excision is continued to the right trigone, staying well below the membranous septum. Care must be taken to note the thickness of the inferior septum seen in the echocardiographic 4-chamber view, because it is often thinner than the anterior septum seen on the long axis view. The anterior edge of the initial incision is then grasped and continued to the left trigone, removing another rectangle of muscle. The incision can be carried closer to the aortic valve in the anterior septum here, as there is no conduction tissue in this area. However, it is important to maintain a ridge of tissue, allowing the malleable retractor to grasp the LVOT. This ridge is excised later. Fine adjustments are made to the retractor throughout the procedure to maintain excellent exposure deep into the ventricle. You will notice that as each rectangle of muscle is removed, it is arranged on a towel in the patient's lap, reconstructing the septum as it has been removed. This process is then repeated deeper in the ventricle at the level of the mid-papillary muscle. The extent to which the myectomy is carried toward the apex is determined by the location of septal hypertrophy seen on transesophageal echocardiogram. We have found that the entire depth of the ventricle can be accessed through a transaortic approach. In cases of more difficult exposure, there are several techniques that are helpful. First, the left pleural space can be opened, as with harvesting an internal mammary artery. Additionally, one can use a folded Raytec on the end of a ring forceps to push gently on the apex of the heart and bring the septum into view. For apical myectomies, which we also perform through a transaortic approach, thoracoscopic instruments can be used to extend the reach of the surgeon.
So you can see we're getting very far within the ventricle. And I think of it as working inside a cave almost. And I'm trying to carve the roof of the cave back and forth with this scalpel blade. And then make sure I don't go too far, because on the other side is the right ventricle. So I'll move on to the next slide. But this would be something typical of most myectomies. You can see this is in inches, almost 2 inches wide, 5 centimeters wide, and this is from side to side. And then similarly, almost 5 centimeters to 2.5 inches of muscle towards the tip or apex of the ventricle. And this is what's required. What's really important, and this is where the experience comes in, is the amount you take in terms of thickness varies from side to side. So some sides of the septum are thicker than the other. And this is why it's so important to have great imaging studies to help you out. This was something that intrigued me when we began to look at some of the patients who had outflow tract obstruction, some with hypertrophy, some without much hypertrophy. And I noted that this angle between the pump, here's the pump, the left ventricle, and here's the pipe, the aorta, became a very sharp angle. And any engineer who designed a pump would not design the pipe to fit in the pump at a right angle unless they had to. And when we're born, this is not how it is. It's almost a straight shot from the pump to the pipe. But as we age, as we have hypertension, as maybe we add a little belly fat, and the tip of the heart, the apex here, starts to move up from, let's say, down just below our left rib cage, moving up towards our left our left clavicle. And that changes the axis of how the blood gets out of the heart. And I think this is an important aspect of why people develop outflow tract obstruction later in life. And this is just an example of, by having that right turn that the blood has to make, the blood gets shot underneath the leaflet of the valve and gets popped up. And this hump of septum, or this acute angulation, that is just a geometric change, increases the likelihood of obstruction. Harry pointed out these cases. This is a case, again, without hypertrophy. And this is one of the things I really thought a lot about in the late 90s, is what can I do to help these patients that have no hypertrophy? Often they've been young patients, young athletes, to avoid having an artificial valve in place and saving their native mitral valve so they can avoid blood thinners, don't have to worry about antibiotics. I could replace the valve, and that's what showed you. But what I did, and it was a couple iterations, I had to think a bit about it, was to recognize, as Dr. Levers pointed out, that these papillary muscles are probably the biggest problem when it comes to this. And they are very floppy. They're not well anchored, as I call it, back away from the septum. It's just the way they developed. And so I developed this really simple technique where you could go through the aortic valve. You can see the papillary muscles, actually better than if you went through the left atrium. And then you find a spot to anchor them. You pull them back, and that pulls this leaflet away from the septum, and then you don't have obstruction. And Dr. Lever pointed that out to you, and it's been a real valuable tool to save patients' valves when they don't have much in the way of hypertrophy. And this is just the echocardiogram after a procedure like that. And finally, the mitral valve is a living tissue. And you can imagine if it's being pulled or pushed up towards the septum 60, 80, 90, 100 times a minute, it grows, it stretches, it elongates. And so in this case, we did a modest myectomy but we also removed this elongated mitral valve tissue that was causing it to, that flipped up towards the septum. Sometimes I fold this over with a suture, sometimes I cut it out, but the very basic principle, which I teach my residents and fellows, is you have to think of both muscle and valve when you think of outflow tract obstruction. You have to inspect both, and you have to be prepared to act for both. Act on both. Sometimes the septum's really thick, you don't have to worry about it. It's all muscle. Often it's a combination of the both. And that was a quick run through of 25 years of surgical experience in 8 minutes. So I'll turn it over to Betsy.
Unmute. So thanks. That was great. I am going to share my screen quickly and go through. Let's see here. Okay. Can you see that, our slides? Okay. All right, great. So, you know, as everybody has mentioned, our Cleveland Clinic physicians and surgeons have been treating hypertrophic cardiomyopathy and actually reporting our outcomes since the 1980s. And people often call us and ask them, you know, well, how many do you do? How many surgeries do you do? And Dr. Desai showed those slides, but they're right on our website. We've always had a culture of transparency at Cleveland Clinic. So please visit our website to see the outcomes that we have, and you'll find a lot of the answers to your questions. We have a multidisciplinary team, as we described. We have our Hypertrophic Cardiomyopathy Center has been one of the first centers of excellence we actually brought together in the Heart, Vascular, and Thoracic Institute. And so we do have physicians and nurses from cardiovascular medicine, cardiothoracic surgery, pediatric and congenital surgery, pediatric cardiology, genetics, and psychology. So this gives you a whole realm of care that we can provide here. And we've had patients come and they brought their kids, and the kids are seen in pediatric cardiology, and the adults are seen in our adult cardiology, hypertrophic cardiomyopathy centers. And they may see the geneticists together. So it's really can be a family affair, and we try and meet the needs of every patient and their family when they come. So no matter where you are in in your care, we can help you find the care that you need. And I always look at this as, where are you in the journey? So we have patients that, are just learning. They just found out I have hypertrophic cardiomyopathy. Lisa brought this up with that cat picture, which was so funny. And it's like this shock, like, what does this even mean to me? And I have a group of nurses that I manage, and we are called the Resource Nurses in Heart, Vascular, and Thoracic Institute. And our nurses have an average of 20 years of cardiovascular medicine experience, some of them 40 years, if you can imagine, working at Cleveland Clinic. So they have this breadth of knowledge. And we try and make it as easy as possible. So you can call us, you can chat online with us. We have an email address, and we can help patients with information, resources. Sometimes if they haven't, which seems hard to believe, Lisa, if they haven't even heard of the Hypertrophic Cardiomyopathy Association, we say, talk to other patients, go visit HCMA and see what else is happening out there and see what their experiences are. So we try and connect you to the right provider to meet the needs of you and your family. Some patients already know, I need an appointment. I've been told I need an ICD. I've been told I need an echo. I know I need a cardiologist. I want a second opinion. So we have a cardiology appointment line, or you can fill out a form online, and we will make sure that you get the care that you need. We have protocols developed as part of our HCM center. And so we make sure that you get the right testing. We review records prior to coming here or when you come. So we want to make sure that you get all the testing and see the specialists that you need As Lisa mentioned before, you might need to see an electrophysiologist, a cardiologist, and sometimes a surgeon as well when you're here. So we will make sure that you get those scheduled visits. And a lot of people ask, well, do I need a doctor's referral? And you really don't, unless your insurance requires it. We have many patients that self-refer to come to Cleveland Clinic and get second opinions or third opinions, or come here for care. Patients that need surgery, we have a phone number, and again, you could just fill out that web appointment. We have a great process. Our surgical process at Cleveland Clinic is like a well-oiled machine that we've refined over and over and over again throughout the years, so that we make it as easy as possible, especially for patients that are traveling from afar. They can send in records for surgical review, and our teams will work with the patient and see what type of surgery is needed, try and plan as much as possible. And then we plan, if possible, a large percentage of our patients can have a one-trip visit for pre-testing, have their surgery, stay at the clinic, for the days of their recovery, see our post-op outpatient area, and then go right back home. So, and traveling from afar, we try to make travel as easy as possible. Like Dr. Desai said, sometimes people are worried about coming to the Cleveland Clinic. They think it's a large place, but we really try and make patients, we put patients first. That's our motto at the Cleveland Clinic. And so we have hotels very close. We actually have one connected to the Cleveland Clinic, so you can just walk across our skyway right from the clinic and go to your appointments. We have travel guides available. We have a medical concierge that can help you with travel arrangements. When you're here, we have an actual website that you can put in what parking garage you parked in, and it'll help you with walking directions to whatever desk you need to go to. And we have red coats that are kind of like guides that you might see at Disney World or, somewhere to try and help you answer your questions when you get here and direct you on your way. And our employees are all trained to put patients first. That's part of our culture at Cleveland Clinic. And so we're all here to, if we see a patient that needs help, we're there to help direct them and walk them to an appointment. And again, our resource nurses can help you with information. So call us anytime or email us, chat with us, and we're here to answer your questions. International patients, we have a global patient services team, and it's very easy. You can email them or call them. Some people prefer that. And they are there to connect international patients with the right provider. There's a lot of financial questions that come into play. They can talk to you about that. They will connect you to interpreters. And their website, again, has a lot of information on it about how to connect to them and answers a lot of questions that global patients have. But we are very used to patients coming from all over the world. And I think all 50 states to come to Cleveland Clinic. So traveling to the Cleveland Clinic is not unusual at the clinic. Some people aren't really sure where to start. They just have a lot of questions, and that's the job of the resource nurses. So we want you to know that we are here for you to answer your questions, and it's okay. It doesn't, the questions can be as silly or as, you may think, is it okay for me to ask that question? Yes, we have had all different types of questions to our resource nurses. There's nothing that we won't try to answer or get you the answer for. What happens when you get home? That's also another concern about people who are traveling for healthcare. And at the Cleveland Clinic, we have MyChart, which is our electronic medical record, and it provides you with access to your medical records, your after visit summaries, your discharge instructions, your lab results, and you can message your doctor through MyChart. Our follow-up visits can be done through virtual visits or in person. We do a lot, especially with everything that's happened with COVID over this last year, that every doctor is trained in how to do a virtual visit, and that's not unusual. And we communicate closely with your local doctor. As Lisa said, you don't want to not have a local doctor. So we want your doctor to be well aware, but we also want to be there for you and keep connected to you. So those questions that are very pertinent to your hypertrophic cardiomyopathy, we're here to answer those. And after hospital discharge, patients are provided with a 24/7 phone number. We're here to answer your questions either with a nurse or our healthcare providers. And again, those could be anything from going over discharge instructions or your medications when you get home to more, involved questions about how you're feeling, and you want to make sure that's normal after surgery. So we are available to answer questions throughout your entire journey of care. Everybody's asking about COVID. So I just want to mention that I always tell patients that I think the clinic, I feel more safe there than going to the grocery store. We've been I think we're one of the national leaders in helping not only healthcare, but other industries know how to care for our environment as well as our providers and patients that come in. I think patients feel very safe when they're here. We have a website which is all about the coronavirus, and because things change from time to time, like when we first started this, you couldn't have a visitor. Now you can have a visitor, and whatever tomorrow will bring. This is the website that provides you with all the information, videos, how many visitors you can have, what should visitors know about coronavirus, how do we protect them. So please feel free to take a look at it and see the information there. Our key takeaways are really that we have a multidisciplinary center. We make appointments and travel as easy as possible, and we are here to help you from beginning to end. So I want you to feel welcome and know that our team is really here to care for our patients. And even before you become a patient, we know it's a big decision to come to a different place, a different state, a different city. And we just want to make that as easy as possible for you. So please let us know if you have any questions. And I will go ahead and take it away, Lisa.
Thank you so much, Betsy. That was really, really helpful. And I'm going to, oh, there we go. And I'm going to go over a couple of items here before we dig into all of our questions. So everybody, I want you to look at the chat feature, the little chat bubble at the bottom. And in that chat feature, there is a link. Do not use the link right now. It is not active. We're going to answer some general questions here in this group. It'll be filmed on, we're being filmed. This is being recorded. They'll be on Facebook, and I will be asking some of the questions that have come in through the Q&A feature, and we'll answer those out here in the meeting. After we conclude, I'm going to tell Julie in like 5 minutes to go open the other room. If we were in a conference center, we would have breakout rooms down the hall. So I'm going to give you that link, and that's going to take you to the room down the hall. And there we can have a two-way conversation. That will be a meeting. This is a webinar. So everybody that is in as a participant, you can use that link and then come meet us in the meeting room. We did this in the practice. Harry, don't look worried. You'll get it. You just hit the link and you'll just fly over there. I will be waiting here until everybody kind of leaves the meeting, and Julie will be going over to the other room to open it so that you can all go over there. When I say go, we're not going yet. I want to go over a couple of points that I either missed or I thought were interesting during everybody's talks. Going back to Milin's talk where he mentioned the HCMR study, which is the study using MRI technology to understand HCM better. I want to give a huge thanks to one of our sponsors of this meeting tour, Cytokinetics, for stepping up with $1 million grant to fund HCMR moving into the future. That was just announced within the last month. So thank you to Cytokinetics for that amazing gift to the community. We're all going to learn a lot from HCMR. Additionally, we mentioned the Explorer trial, which is the trial of mavacamten from myocardia. We did a talk on Facebook with Jacopo Olivato, the principal investigator who presented the data. Sorry, I lost a word there for a minute. presented the data at the ESC, the European Cardiology Conference, a couple of weeks ago. So if you want to see the latest and the most accurate, up-to-date information on Explorer, it's right here on our Facebook page. You can hear Dr. Alivato explain it himself. So you can go to HCMA on Facebook. You can watch the interview. Somebody mentioned Dr. Cooley. I think it was you, Nick. I actually spoke to a man this month who was diagnosed by Cooley in 1964. This gentleman is 88 years old and doing really well today. So I got a kick out of that because I'm an HCM historian. And Nick, do you remember, this is a challenge question. When I came to Cleveland Clinic,
No.
myectomy, and y'all let me come in and watch firsthand so I understood what our patients were going through. And I said if I could do anything else other than what I do, I'd be a cardiac surgeon. But, you know, I have HCM, so that wasn't going to happen. What song was playing?
Oh, no. I have no idea. What was it?
It was, I didn't realize the radio was going. I was so enthralled with what you were doing and how this all worked and just how magically chaotic the team worked together. And it was wonderful. I didn't realize there was music until you're about ready to restart the heart. And then I hear this song come through and I started laughing. It was Blue Oyster Cult, Don't Fear the Reaper.
Oh, shit.
So every time that
Oh,
song comes
my.
on, I think of you. And every time I think of myectomy, I think Don't Fear the Reaper. So
Oh, my. Yeah. Well, I'm glad you enjoyed your time there.
thank you.
Well, I would have guessed Staying Alive or something like that.
It could have been, but it was Blue Oyster Cult, Don't Fear the Reaper. And I just thought that was so apropos.
That's
Okay.
funny.
So we have a lot of questions. I'm going to go through them and kind of point them to some people because we are running a little bit late, surprise, surprise, but we can go through some of these questions and then we can go to the room in a few minutes. So there was a COVID question. I think Betsy handled that one quite nicely. I'm going to go to some of the ones that Melinda was kind enough to answer for our participants online. So one of the questions is it possible for obstruction to come back after a myectomy is performed by a center of excellence? And I'm going to qualify this further. What is the likelihood of it coming back at a center of excellence myectomy versus some community hospital who doesn't do a lot trying to do a myectomy? So Nick, you want to speak to recurrence of obstruction?
Yeah, in our experience, it's very rare. I hope the video showed in the pictures that I think the key to having no recurrence is that you have to take a very large piece of muscle. You have to open up the left ventricular outflow tract. And so the advantage of going to a center of excellence is you know how much you can take. You know how much you can take safely, and you know how much you need to take for there to be no recurrence. And the recurrences I have seen, they're not really recurrences in the sense that the muscle grows back. It's simply that very wide amount of muscle that should be taken was limited to that very small middle strip, and the other areas were causing the obstruction. So it was just failure to do a complete myectomy in my experience.
And I will preface some additional thing. Exactly, I completely agree. You know, what I answered to that is the reason for a redo myectomy, need for a reoperation is either an incomplete job the first time around or under recognition of, mitral valve or papillary muscle problem. Occasionally, I've seen just one or so patients where, you do an operation like an aortic valve surgery for aortic regurgitation, and then the heart shrinks, and all of a sudden they start developing SAM. That is not real HCM. So, occasionally some other things pop up, but like Nick said, it is mostly due to an under-recognized problem the first time around.
I will add an asterisk to that, and you can agree or disagree. If it's done in a child, there is a higher likelihood that as they age, it can grow back in because the body's still growing.
Yeah, you just can't take, you when we do, and I've done a number of small kids, their hypertrophied septum still might only be 9 millimeters thick. Right. So, but it's still hypertrophy because it should be 4, or it's 11 and it should be 7. So you don't have a lot you can take. And then as they grow and you get more hypertrophy, the theory is that we don't stop we stop adding muscle cells once we reach maturation. I mean, they can get thicker, but they should not replicate. But kids are still growing.
Yeah.
So.
I guess the data says we generate until 25 and everything past that's downhill.
Yes.
So don't worry about that. Okay, Larry, thank you for letting me know that you're running for Kansas State Senate. Congratulations on your run. I wish you success, and we can talk offline about legislative initiatives for the state, hopefully once you get elected. If you don't get elected, we'll still work on it. So we have a question about metoprolol, and I'm going to put all of these together. These are the questions that some people don't like to ask, but they're really important to quality of life. Does metoprolol cause erectile dysfunction in some people? And can Viagra or Cialis be taken safely for those with hypertrophic cardiomyopathy?
I can answer that.
Thank you, Harry.
You can take Viagra, but what I've done in a few cases is I've had the patient come to the hospital. We do a resting echocardiogram and then give them a dose of Viagra and repeat the echo an hour later. I've done that in a few cases, and if they don't develop obstruction, then they can use it. But I always tell people to try to use the smallest dose that they can.
Thank you. There was a follow-up question by somebody else about having a normal sex life with HCM. Is it safe? And who wants to take that one?
I think so. I mean,
Yeah.
I'm going to say yes.
Yeah. Right.
Yeah, exactly. I mean,
There was a very funny conversation at a restaurant in New Orleans. We had an HCM dinner after an AHA conference, and I think it was Mark Sheridan and Barry. Harry, you think you were there, and they were talking about exercise and competitive athletics. And they're like, "Well, sex can get quite invigorating. Do you suggest your patients don't participate?" I admit there might have been like a hurricane that I had beforehand, and I slammed my hands down. I said, "I sure as hell hope not." And I don't think Barry looked at me for a month, but it was kind of funny. So yes, you can have a normal sex life with HCM as long as you're able to walk up a flight of stairs, generally was the rule of thumb, and you should be fine. Let's pivot to genetics. How accurate are genetic tests these days? And if you, as the index patient, have an identified gene mutation that is known to be pathogenic or disease causing, what is the likelihood of the reliability of a family member's screening to be positive or negative for that gene? Is it definitive that they don't have HCM or they do or will?
I can take, and I think I also want Harry to chime in his experience because he may have a slightly different opinion. So if you take 100 consecutive patients that come to an HCM clinic and you do genetic testing, these are random non-related people. You do genetic testing, data have suggested between 30 and 40% of people will have gene positive status, which means other 60 to 70, we just have not evolved to a point where they may be positive. Now, on the flip side, if you have an index patient who is gene positive, in that situation, that's a different story. So there, what we do is we recommend screening all their first degree relatives. And what at least I tell them is if you are positive and your first degree relative is negative, they and their downstream children are free from at least that disease, but they may develop a mutation. They may be unlucky enough to develop mutation elsewhere, but that particular mutation they're absolved of. Now, the problem happens is, what if you, the index person, is gene negative, yet you have all the features of HCM? In that situation, genetic testing does not help as much. So that is typically the advice I give. Harry, do you agree?
No, I think that's right. And I agree with that number of 35, 40% that are gene positive. There are some centers that have had higher numbers than that, 50, 60%, but they may be ones that just happen to, they specialize in doing just genetics and they tend to get a little higher number. But ours have been, over the years, have been in that range of 35, 40%. And clearly I agree, if you have a family and the index case is positive, you should test everybody. And those that aren't positive, you can tell them they're probably all right. But the interesting thing is, over the years, I've had very few patients that I've seen that were like, I can remember a case just in the past year or so that I saw who was gene positive, but echo negative at the age of 15. And then 10 years later, he's now gene positive, echo positive. So the hypertrophy can develop. And, you know, and I always tell patients that are gene positive that they've got to get repeat echoes over time to keep up, see what the muscle's doing. And there may be some people who are gene positive, never will develop hypertrophy, but there are some that clearly do, and you have to keep watching them.
We just did a talk last week, I think last Thursday, a week ago today, with Perry Elliott on a paper he just recently published in August, I think it was, on penetrance of gene positive HCM. How often does somebody who's gene positive convert to phenotype positive? And there was some interesting data there. It's 40 some odd % will eventually, in the time of this study, they went from phenotype negative, no echo signs, to phenotype positive. And I think it was a 7 or 8 year or 8 or 11 year follow-up, something like that. Males were more common to develop, but that doesn't explain why females tend to go into heart failure and have more severe disease later in the experience. So there was some questions yet to be answered, but it was, if you carry the gene, there's a high likelihood that you were going to present the disease at some time. And we have some people who were clear through their 30s and 40s and show up at 50. We don't understand the why yet. We would like to understand that better. I'm going to pick a couple more questions, and then we're going to go off into the private room. Julie, you can run away and go get the meeting room set up and set up the chairs and put the lights on. Make sure the coffee's ready. No, there's no coffee. So Julie's going to go off and do that. So we didn't talk a lot in our sessions about arrhythmias. And there's a question about how to treat atrial arrhythmias in HCM. This is complicated, and Nick, you get involved with doing maze procedures, but when do we get involved with being more aggressive when there's no obstruction, so you're not going in for surgery, so maze isn't the option? How fast do you pull the trigger on radiofrequency ablations or cryoablations for atrial fibrillation?
Malin?
I can talk about that.
Yeah.
If we have patients that have, let's suppose we have patients that have outflow tract obstruction and they are seemingly doing all right and develop atrial fibrillation. I'll take those people, you know, maybe they have resting obstruction, but they're feeling fine, no problem. They have their first episode of atrial fibrillation. I've been taking those people to the operating room and at the same time having something done to the left atrium, whether they do a maze procedure or pulmonary vein isolation or something of that sort.
So I will tell you, Lisa, and you know what my feeling about AFib, or what Cleveland Clinic's feeling about AFib is. So, you know, there are other centers, you know, it's like AFib causes heart failure progression, or to me, the math is simple. Like Harry said, you have severe obstruction, your LV is going bananas. You need your left atrium to help you with functioning, and you go into AFib. In this context, you start feeling like crap. There is no other better way of putting it. You start feeling like crap, and you know, the longer you wait, the worse off you're going to be, the less the likelihood of your AFib improving after a maze or what have you. So, you know, this is an evolving context. The other comment I will state is every Cleveland Clinic database related to HCM we have looked at in the last 15 years that I've been here, AFib has come out as a major player associated with mortality. Not just heart failure, but flat out mortality. So there is something to be said about AFib in the context of HCM. The second thing is, what I tell patients is AFib is a bad actor, and it is much harder to treat AFib in the context of HCM. So ablation, the success rate is less than 50%. Maze procedure, you know, with mitral valve maze procedure, success rate is fairly good, 70, 80%, maybe Nick will agree more. With HCM, it's not as good. So to me, I don't want people to develop AFib. The next frontier could be, could the drugs impact some of these newer drugs, could they impact development of AFib? Should we be operating people before they develop AFib? I mean, if their left atrium is big, if they're showing signs of being a bad actor, should we be doing something to preemptively before they go to NYHA class 3 or 4? I mean, I think these questions remain, these are important questions.
I agree. Okay, so we're going to go back into myectomy world. So people want to know, can I get a myectomy in South Florida
Yeah.
by next Madeira?
Well, I responded to somebody. I did. I do have privileges at the Weston campus. I went down there now twice. We were planning to do it on a quarterly basis where we would have a number of patients all ready for surgery with Craig Asher and his team. COVID threw a big wrench into this effort, or this year. I think it works well. The team, I really thought the team down there, the nursing team, the OR team, was no different than at the Cleveland Clinic in Cleveland. Craig was available around it every day. The contemporary of Harry and Malin. So yes, I hope to resume that in the first quarter of next year. I think it's important because it's very challenging, especially in the winter, for patients to travel. It can be expensive. We have insurance challenges as they narrow the network. So I plan to resume it as soon as we can sort out all the COVID issues, because I think it does help to serve the needs of the patients in South Florida.
Thank you. Are obstructed patients less likely to survive as long as non-obstructive patients?
That there's data that has suggested that obstruction is a bad actor and relieving obstruction is associated with improved outcomes. So, people with resting severe obstruction, they do worse than people who have provocable severe obstruction versus who are non-obstructive. Now, there is a small group of non-obstructive folks with predominantly diastolic dysfunction or bad stiffness of the heart. That's a unique group of bad actors where their trajectory may be slightly different.
Could I bring up another thing?
Yeah, please.
There are patients who have dizzy spells that have obstruction that get ICDs, and I think before they need them.
Yeah.
And I've had patients that have passed out with an ICD that never fired because they had outflow tract obstruction. So if we can be fairly sure that the patient, we risk stratify them with MRIs looking for the degree of scar and all that kind of stuff. And if they have severe outflow tract obstruction and they don't have much scar, and they get dizzy spells, we're going to operate on them and see how they do, because it's to put that ICD in somebody who probably never needed it. You got to be a little careful about that. And it's not to say I don't use ICDs, but if you have just dizzy spells and outflow tract obstruction, I think the first move is to do surgery.
And Lisa, so there's this prevailing thought process. It's like, oh, the risk or decision making for ICD is Highway 75, and the decision making for surgery is Highway 70. Not really. Life ain't two different highways. I mean, sometimes there's some overlaps.
Right.
Okay. Sometimes, and that is where a Mac Daddy cardiologist like Harry Lever is the difference maker. Okay. This involves nuanced decision making, and not every syncope is the same.
Right.
It is good. He's absolutely right, because we've had so many patients like that. My ICD is not fired, I still keep passing out or nearly passing out. Absolutely.
So I'm going to cover a couple of the questions regarding the transplant pathway pretty quickly. It's rare. I'm in like a 4% group. I know statistically tonight, Amy and I are both transplant patients and we're here. But so we're a little overrepresented tonight, but about 4% of patients with HCM will go to transplant. Somebody asked, how many people who have myectomy go to transplant versus not? I don't necessarily know that the myectomy is a factor or a player in who is going to head to transplant. It's It's a crapshoot.
It's a crapshoot. Yeah.
I've kind of had the feeling that there may be those that end up in transplant, maybe some of non-obstructors rather than the obstructors.
And
But
Lisa, I will state this. I've been thinking about this, and which is where I think the QOL study is going to help me understand a little better. Do every person that we relieve obstruction get better and become the next coming of Usain Bolt and a marathon runner and all that? We don't know. There may be a small group where you relieve the obstruction, but their underlying problem may be a combination of obstruction and stiffness. Maybe some proportion of those patients eventually, if you follow them long enough, they may end up with transplant. But like you were right, in the overall HCM population, 3 to 5% undergo or need transplant, may need transplant, and after myectomy, the number I think is even smaller.
So we're going to have an offline conversation on this because there are these groups of people that I've spoken to over the years and their pathway to myectomy for whatever reason. And there's a spidey sense in me that says, I don't think it's going to work because of how they describe their symptoms. Mm-hmm. They don't just seem that classic, this is going to be cured by getting rid of obstruction. Their symptoms are a little bit different. It's really hard to tease them out. And the ones that I went, I don't know that this is going to work. I've been right in my instinct, and it's more about word choice and explanation of symptoms than anything that you see on the clinical documents. So we need to talk about that. We'll get there later, Dave.
I think you're right. I think you're spot on. And if somebody has severe symptoms, has noted a relatively rapid decline, atrial fibrillation tends to be more prominent, atrium tend to be bigger, and the gradient tends to be lower. Those folks strike me as the ones that may be what you're thinking about and head more towards transplant than get better with myectomy. I think you're spot on.
So the other question was, what does the EF tend to be when you head to transplant? So we know that HCM has these supernormal EFs 65 and better. So generally speaking, when the EF goes into the normal range, we start to watch it more carefully. But once it hits 50 or under, you really have to watch that pathway. And I think we're all learning this now. My EF stayed at 50, Amy stayed at 50. We didn't go to this 20% EF. We had diastolic dysfunction, stiff hearts, and that little stiff heart was still able to get 50% of the blood out per contraction. But the ventricle was tiny, and 50% of nothing is nothing. So I think if your EF is dropping, you really need to be more than maybe the obstructed patients. You need to be with a specialist who's going to get you to transplant evaluation timely.
And it's not just the EF, Lisa. I think, but a dropping EF, you demonstrated that you are a bad actor or your heart is a bad actor.
Thank you for saying I was not the bad actor.
Yeah, I mean, Nick has operated quite a few transplants in his other roles. So, I mean, it's exercise. I mean, there's a whole lot of testing that involves before you decide who ends up getting a transplant. But you are absolutely right. No, supranormal EF, and now you are 55. Now it's 50. It's 48. You got to start to worry. Absolutely.
Well, that we just celebrated, or just did. I don't know if you celebrated as much as accomplished our 2000s heart transplant, and to your point earlier, when you had those, I think, buckets or baskets of how you have to have a multidisciplinary, multi-specialty team, because the spectrum of how patients present and what they need and where they will evolve over their lifespan varies tremendously. And that sort of comprehensive specialty groups are all at the Cleveland Clinic.
That is true. I'm going to take 2 more questions here, and then we're going to go off into the private room so we can ask one-on-one questions and be a little more informal there. If somebody had a myectomy and they're still getting symptoms related to after eating, specifically with carbs, I think carbs are the enemy of the world, but that's an entirely different story. And I love them and they love me. They like to stick around a while too. So do we know if there are foods that trigger obstruction worse than others? Is this an area that we can investigate to help maybe create a better eating plan for those with HCM. And if somebody has periodic symptoms that seem like obstruction related symptoms after the myectomy, what should they do?
Well, one thing I tell people is to avoid alcohol. I think that there's an increased incidence of atrial fibrillation with alcohol. It can vasodilate you. We've seen a few people that with obstruction that gets worse after alcohol. So I tend to tell them to stay away from that. You know, other foods maybe you have to worry about is in terms of fluid retention is stuff that's very salty.
And you know, to your point, yes, completely agree with Harry. My first thing is if somebody's complaining of postprandial symptoms like this, and especially, I mean, you know, trust but verify, as Ronald Reagan said. You know, I would want to make sure I do a detailed evaluation, make sure you do not have residual outflow tract obstruction, because you know that is always on the table. If I'm convinced that my team, our team has done a thorough evaluation and not left any stone unturned, then we can talk about all the other things.
The other thing about that is I haven't done it a lot of times, but I've done it enough to see an effect that I'll do a stress, have the patient eat, do a stress echo, and then sometimes those people really do develop outflow tract obstruction once because the blood is taken away from the heart, goes to the stomach, and it may shrink a little bit. So we have them eat and then come and do the stress test, which a lot of people don't do.
I tease people all the time and I say, don't study for these tests. You know, stay up late the night before. Don't be your best self on test day. Be your normal self on test day. So when you're going to go do, you know, a stress test or you're wearing a Holter monitor, do not wear a Holter monitor and don't run up the stairs, and don't ultimately, you know, hydrate to the perfect amount. Be normal, and in fact, maybe be a little bit bad that day. So we can see the worst you, not the best you. Right. Don't study for the test. I know that's like against everything you were ever told, but for these tests, don't study.
Right.
Okay, I'm going to handle one more question here, and then we're going to go. So for those of you who are not interested in hearing a question and answer about mavacamten, you can start going to the meeting room. Julie's sitting over there wondering where everybody is because she's like, Lisa's talking again. So the mavacamten trial, we talked a little bit about it during Milan's talk. Mavacamten, do you think, number one, is there any trials right now for those without obstruction or those post-myectomy who still have some residual gradient? Can they get into the study? And for those people, and I'm going to phrase this very carefully, for those people who are on a myectomy pathway and are interested in learning more about how to get involved in the clinical trial, what should they do?
So
I
will take that question. The first thing is there is a planned study on non-obstructive HCM that is in the horizon, number one. So in planning stages, so more to come. Second, if you are, you know, post-myectomy specifically, I do not believe there may be something planned that I'm not aware of. I know for the Valor HCM trial that I alluded to, if you had a failed alcohol septal ablation, and then there is a small proportion of folks who we would consider for septal myectomy, those patients, yes, they could be on an individual basis, be considered for the Valor trial. The third is, you know, you have a high gradient and you are on your way to surgical myectomy, but maybe you think you are not there. Well, beauty lies in the eyes of the beholder. So your perception of you are not there could be because you have adopted your lifestyle to a lower level. I mean, I'll tell you, just recently, about a month ago, I saw a patient who comes in from the Brooklyn suburb of New York, you know, and he passed out. He passed out while going to see his son-in-law on the third floor. His gradient is 100 millimeters. So his wife tells me he's no longer symptomatic because now he no longer visits his son-in-law. The son-in-law comes to visit him, you know? So people don't realize that they have adapted the life. So, you know, what I would say to the person specifically, you know, I have a high gradient. I don't think I'm ready for myectomy, that, you may want to get yourself checked out to formally decide whether or not you are a candidate for that. But I think the Explorer trial addressed that kind of a patient. And, the trial, as you very well know, was strongly positive in favor. So, once the drug gets approved, so that person potentially would be a candidate for that.
Very good. Okay, everybody, thank you so much for participating in this live session. We're going to end the Facebook feed now, and we are going to go into the private group room for a few
Lisa,
minutes.
can I interrupt? I have, I have to go
You
to the
have a
Browns
football
game.
game? Okay,
Yes,
Harry
I
will cover for you. We got you.
Harry,
Go watch your
I
football
gotta
game.
go.